We'll talk. Good morning, everybody. So today we will be talking on interlocking nail, particularly tibia. Tibia is commonly used. So we'll discuss about the various parts of the nail, indication, contraindication, how to do it. All these things we'll be discussing. So as usual, before going for the subject proper, we must have some philosophy. Yes or no? Today's philosophy is na jayate miyate kadasita nayang bhuta bhavita na bhuya. What is the meaning of this? What is the meaning? Meaning this is actually from Gita. Gita says that there is Atma, there is no Maran. So it is Ajar and Amar. So it is happening past, present and future also. So Atma is Amar, that is what they are saying. Nayang bhuta bhavita na bhuya. It's not happening last, past, today, and it's also not going to happen. Yes or no? So that is about the Atma in Gita. So that is one philosophy. So every day we used to have some philosophy. Today's philosophy regarding Atma from Gita. Okay, fine. Now let us talk about the tibia interlocking thing. But before that, you know that what is the recent trend of fixation of long bone? If you look at this recent trend throughout the world, you will find this trend of long bone fixation is going towards the nailing. And of course, keeping aside this metaphyseal part fractures. So epiphyseal, metaphyseal component, interarticular fractures, and particularly metaphyseal fractures, nowadays very new good implants are coming up, a locking device. Since this is available, so by and large, most of the orthopedic surgeons, they limit the nailing particularly in diphyseal fractures. Since metaphyseal fractures and interarticular fractures are better dealt with the specific pre-designed, pre-controlled locking plates. So most of the surgeons, they prefer to go for plate. Though there is always a tussle between the plate group and the nail group to increase their indication. So they may be getting some literature also where people will be trying to go for fixation of nail even in interarticular fractures. So that is why some divisions are coming, some reconstruct nails are coming up, some modifications of interlocking, locking, particularly bolts are coming up, so the directions is can be addressed. And the effort is also on for the plate persons also, plate surgeon also, to increase their indication. So this is tussle of word. But by and large, what is the consensus? By and large, the consensus is to go for the interlocking nail fixations in the diphyseal fractures, and for the metaphyseal fractures, interarticular fractures, it is better to go for the nail plates, since they are giving predictable good results. So conventionally, we are now limiting to this. So necessarily, Nitin, good morning. Good afternoon. Okay, we will continue. We are talking about the nail today. So if you go back to the history of nailing, I have already mentioned, particularly while talking about the K nail. So K nail invented in 1930, something like that. And Kunsars, then subsequently he had also invented your V nail, V-shaped nail. So V-shaped nail to adhesive femur tibia, same. Now that V-shaped nail is on axis. You also remember one word sometimes, on axis and off axis. On axis means on the line of your axis of this. But there is sometimes problem with the particularly encountering for the entry point. So violating of the normal structures or the some it become unconventional sometimes to go for this introductions of the nail on axis. So there is that is why the concept of off axis is coming. The off axis concept has come particularly for tibial nail by Harjos. Harjos actually he has developed this angle. This is known as Harjos angle. This angle is meant for what? So, introductions of the nail not in the same axis, rather it is off axis. Yes. So, it becomes a bit conventional without having some difficulty or not going to violate some important structure. That is why the concept of off axis. Similar things are also there for the femur as well, off axis, on axis. Piriformis, tip of the trochanter. That is why then and then that is why this nail is not straight, it is angulated and it is 110 degree by Harjos. This is second addition to the nail. Third point in this nail development, if you go back the history, in the Gorsig camp of Germany, they have given this concept of your locking ball. As you know, we had the problem of instability, rotational instability with the canal. Yes or no? Otherwise, this nail is also good, but we are unable to effectively address the rotational instability part. That is why this concept of your locking coming, and is still used. And today there is also some sort of modification to locking ball. The concept of dynamism is also added there. Now next generation is coming to change the directions of the locking ball, yes, so as to address some specific conditions also. Are you getting my point? Then if you find these nails are also, see, this is in the same axis, anterior posterior, yes. So pupils are also coming from the lateral. So place the screw is anterior posterior, here it is lateral, but also combination. Another addition is combination, then the screw is being passed here from lateral side in this coronal plane and also in the anterior posterior. Whenever necessary, depending upon the flexure configurations and the morphology, so you may address it. So there is some modifications going on the nail also. So that is your history of nail invention, K nail, Harjos angle, then locking ball. We know there are two types of locking. What is the size of the locking bolt? Anybody who knows? What is size of the locking ball? The locking ball size is 3.9 if the nail is small, if it is going for 8 mm or diameter. If the nail is bigger in size, then you have to increase 4.9. So 9 onwards it will have 4.9. ठीक है 4.9. So 3.9 and 4.9 are the size of the. These are not screw actually. This is called bolt. Bolt is a bit different. Bolt level. So that is a little bit of your nailing. Broadly, where in what aspect you do. Now, you know the indications. I have also mentioned about the indications. Nowadays, the indication is extended to encompass, to include the all type of compound fracture excepting type C. Otherwise, Gastilo 1, 2, 3A, B all are being entraced by his. But mind it, there is a question to alarm you, that textbooks is all saying that you can go for the nailing for the compound fracture also. But you know, you must have this courage to say that this patient is not coming with infection. If the patient is coming already a infected condition, probably it is dangerous to put a nail inside. If he is coming early, compound fracture, your debridement is good, everything is, you are happy, you are having this experience of doing so, better go it. But if he is coming late, there is pus coming out already from the infected wound. It is a detrimental situation to put a nail inside. Probably this will lead to a consequence of non-infected non-union, and this is a nagging patient for you. He will pull your leg throughout your life because it is a problem which is not going to be solved easily. So The alarming word is should to be alarm always that whenever you are in doubt, better not to put the nail. However, whenever you are very much confident about the situations that I have cleaned it nicely, everything is fine, then you can go for the nail. But there is a alarming word always, debridement is macroscopic. However, the danger of microorganism is microscopic, which we cannot see. Are you getting the point? These are the dushman, these are the enemy for us, which we are unable to see. We have presumed that doing the right man, that we have cleaned it relatively. But you are not 100% sure about the infection organisms. So, in a situation when you are in doubt, it is a word of alarm that never try to put a nail there. Better to put a fixator for some time, look at the situations, then switch over to technique anytime, anywhere, let it alone. So, that is the your demarcation point of putting the nail in compound situations. This is clear. So, whenever you are in doubt, better not to put the nail, better wait, do fixator, happy, go for 6th sense. That is a technique which is being used. But in a situation when it is clean, patient is coming within hours, your setup is very good, everything is fine, debridement is good, yes, one can go up to 3B. Up to 3B is okay. So, that is. Now, if it is the indication, can anybody tell me about some contraindication? Where not to put nail? Every time you can go for. Can anybody give some example where you cannot put the nail? Simple. Simple. Simple is if the child is having child with this epiphysis is still yet not fused, is it a candidate for nail? Never. A patient is coming to you with a malunited fracture tibia earlier, now he is coming fracture again where there is some sort of angulation is there. Can you justify nailing this time? Certainly no. Yes or no? So, in a situation in a compound fracture I have told you. So, epiphysis yet not fused, malunited, some say is a burn fracture. Then another alarming point you should keep in your mind, that what about the knee joint? So, in this conventional way of doing nailing today, you supposed to have good range of movement of the knee joint, means you are supposed to be able to flex it. It is true that one can do nailing in fused or fixed knee also, but here the entry point is of suprapatellar. So, suppose if you are going to OT, everything is ready with a nailing technique which is infrapatellar. Everything is ready, but you have forgotten to see the knee movement. In these situations, probably it will be in dangerous situations for you to go negotiate this thing, because for suprapatellar entry point you need a different device technique. So, that should to be clear in your mind that there are some limitation also, that everywhere you cannot go for the nail. So, burn case they are saying not good, they are saying the malunion, yes, that is true, because nail is straight. If there is already malunion somewhere, probably you will end up with a dangerous situations where you cannot negotiate this nail and can split or something do later. Yes. Then epiphysis fusion is an important thing. Always look for the medullary cavity status. If there is no existence, sometimes people may come with a very small medullary cavity, osteopetrosis, something, some of the problems are there. Some conditions where there is medullary cavity is very narrow. Probably these are not a good candidate to go for your nailing. So, you have to be very careful selecting a nail. Jaw is a very commonly used practice, but even then sometimes you may face some problem where you have to be very careful and make it a point to see the patient, a wound and about the knee mobility in this. ठीक है? Now, some alarming condition also, that sometime you may have occult fracture of the upper end plafond, or sometime in the your plateau. ঠিক আছে? Yes, that is another situations where you have to be very careful. Sometimes there may be occult fracture here or here. These are not very good candidates. And in a situation where you are in doubt, probably you should go for a CT scan to confirm this status. If there is profuse in knee swelling, tenderness also there, but X-ray silent, X-ray showing fracture here. But here, to be more in safer side, whenever you are in doubt, this should be excluded, because intraoperatively you may be having some problem of doing so. If you do imaging and other things, probably it is split up, lending you another additional problems of dealing the interarticular, because interarticular fracture was there, which was not evident initially, but later on it may split up and lend to your some problems there. So these are the some situations where you have to be extra careful. As such, it is a routine day-to-day practice to go for nailing of tibia, but these are the situations where you have to keep your mind open and eye open and see yourself when come, because intraoperatively it may be in the problem. Moreover, some important point from the radiological point of view, as I said, CT scan is also important. Another thing important is to that the pure AP view and pure lateral view. Pure AP view and pure lateral view also give you the judgment about the entry point, where you should go from medially, you should go midline, you should go laterally. So where to go medially, where to go inline, where to go laterally? Anybody who can tell me? Straight one online axis. Most of the surgeons, they either go for medially or online for diaphyseal fractures. But if the fracture is very high, 1/3, probably it is logical to go for the lateral side to avoid unwanted valgus deformity. ঠিক আছে? So that is regarding the entry point. And I told you the selections of the entry point is always based on the pure AP view and lateral view. Now, can anybody tell me which is a pure AP view? See, a ray is coming like this from here, your plate is lying over here, X-rays come. Some little bit of rotation may be, yes, it may happen, it may be also rotate like this also. But these are not pure AP view, this may give you some wrong judgment to you. Now, can anybody tell me which is one, how you know that you are having the pure AP view? Pure AP view is that your fibula is here, While you take the AP view, the lateral edge of the tibia supposed to bisect the fibular head in pure AP view. Now, keep it in mind. Little bit of this and this can be also come as a AP view, but as I said, it is also important to go for the entry point at a perfect point. To know this is not for the echo X-ray, it is also important from X-ray that I am in the right track. Your see, entry point means passing the guide wire. Guide wire means everything will follow him. As if going to the Bhulbhelaya, Lucknow, if the guide is not there and if you are going this way, then probably a whole day will be trapped and you cannot find out the route, actual route. So guide is there to help you to which way you are supposed to go. Yes, that is what we follow. If the guide wire entry is wrong, everything is wrong. So that is why always putting the guide on the right track is the first important thing. Everything will follow. So if you are in a wrong track, probably it will be a difficult situation to negotiate sometime. This is not compromising. So that is why pure AP view is an important thing. The importance of pure AP view is that the lateral edge of the tibia will bisect the fibular head equal half. It is called pure AP view. And pure lateral view is the femoral condyles is there, which is overlapping each other correctly. Then you will see only one condyle, that will indicate that it is a pure lateral view. So pure AP view, pure lateral views are also important here. These are important to have your proper entry point. Wrong entry point will lead to disaster and difficult. So that is why pure AP view, pure lateral views are also equally important. Now, regarding entry point, I have said roughly. Then how you have to proceed? Where is the entry point normally? You can go. See, I told you that you can marker pen. You can go through the tendon, medial sided tendon, lateral sided tendon. Most of the surgeons they used to go for the medial sided tendon, medial paravertebral incision. Okay? So that is one. Somebody they say that you can go through the tendon also, through the tendon, infrapatellar tendon. Okay? You can dissect it, no problem. If you do a sharp insection and if you repair it later on with the epitendon sheath nicely, nothing happen. Patient is okay, fine. That is sometimes easy. And most of the time for removal also you have to take that track. So that is one point. And for lateral entry point, lateral incision is mostly done in case of your proximal fragment. If the fragment is very high, you are doing lateral, then it is better to go for lateral side to avoid valgus deformity. So in midline you are going, the incision line is medial slope of the lateral tibial spine. Okay? And that is one point. And in insertion you will find it just anterior to the you have the cruciate, intercruciate ligament, anterior intercruciate ligament, just anterior to it. That is your entry point. Before that, I have to tell you some other thing also regarding the position. That is entry point. Okay, let us go back little bit. Let us go back little bit regarding the position of the tibia. Mane how you are going to do. Okay, carry on. How you are going to do. One is to how to keep the limb in position. There are various techniques. One is to that somebody used to go for the traction. Traction into three ways. One, a foot plate where the traction device is there, that can be done one. Another technique is to go for a stainment pin through the calcaneum, one. Another somebody used to go from the distal tibia also. Now these are the point where through the you can give a traction. But while going for the distal tibia, I will tell you how and where to go. That is one. And how to keep the limb in position, there is various way. One, they used to keep a bolster there and keep it in flexion. Somebody is giving a traction like this, a traction frame. That is also another technique. Yes, somebody keeping the limb free also, doing this manipulation himself while doing these procedures. So there are various techniques for maintaining the position. One, without any doing traction, free limb is, and they maintain it in such a way you can do hyperflexion also. Hyperflexion makes you easy to go for the entry point easily. Hyperflexion, you are going 90 degree hyperflex. 1 point. Number 2, traction frame. 3 point. One through the calcaneum, another through the distal tibia, and another through the foot plate. Yes, these are the way of traction. One group without traction also. Yes, so these are the way people are convenient to do, one can do. But the evo technique is mostly in the frame traction is like this, and a person who is doing in standing position and in this inclined way. Most of the surgeons they used to do even sitting position also. Sitting it is lifting limb is allowed to fall at the edge of the table. That is another technique. So various way of doing so. But some other more important techniques are the use of external fixator, use of distractor. These are the another things. So use of, because most of these surgeons are doing this technique himself alone or only one assistant. Can you take some advantage of the technology to maintain the traction, maintain the reduction and do everything? Yes, that can be done. That can be done with the help of your 2 pin placed, one at the level of a tubular head, another at the level of your epiphyseal scar. Then do the distraction. That can be done with a distractor, or that can be done with the external fixator also. And then can be done with medial side also, it can be done lateral side also. If you are maintaining these tractions, reductions, and then you do not need much assistance to do, because reduction is maintained, then you do all the thing. One point. So I am talking a lot of things. One, to how to maintain the reduction, then go for the guide wire. One, that is one traction, simple traction device. Then distractor or the external fixator. 2. Number 3 is that applications of the clamp, percutaneous clamp. Suppose there is a fracture here. You have some sort of oblique fracture here like this, some sort of oblique fracture. Then what you do? You can percutaneously apply the clamp over here and hold this procedure like this and do this here. Yes, that can be done. Then the concept of your polar screw. Polar screws are basically being done. Polar is actually guiding force. So how to keep your polar actually by the side of your road, the poles. How to park your car means that will guide you. That can be also done, particularly in concave surface. You are going to apply so that you give a direction to it. But there is a problem with the polar screw also, that sometimes doing the reaming, doing all technology, probably a difficult situations for you. Beside this, also one technique in compound fracture can be done. Anybody? Can you say anything more than this? Yes. Another technique which can be applied particularly on compound fracture is go for a temporary fixation with a plate. Supposing this is a compound fracture, like this, it is open wound. So temporarily you can have a very small plate DCP. You can unicortically fix it this area with two screw here, a unicortical short screw. That will temporarily mobilize, maintain this reduction and do everything, then remove it. Somebody even like to keep the plate there in situ for long. Somebody used to keep it if it is able to cover the wound, they used to keep it. But this is another simple technique by which you can maintain the reduction till there is all instrumentation is done. So these are the various techniques you can take the help. These techniques are mostly applicable while you are alone and do not have much assistance. You can take the help of your technology. These are traction, external fixator, application of the plate, application of the clamp from percutaneously. So many techniques can be done. This should be all important thing, that the idea behind of doing this thing is to keep the guide wire in proper position. So you are putting this guide wire here. You are putting the guide wire here, you are going like this. Going like this. So while you are putting the guide wire, so you sometimes use the guide wire like your ball tube. So ball tube sometimes it is bend. So bending help you to negotiate this reduction sometime. So as to keep it. And it is being done. Okay, this is fine. But how far and where and how? How far, where and what position? That this in AP view it should be in center, and in also lateral view it is supposed to be center. That is your ideal position. Then hinge it on the subcondylar bone such a way that while doing only position it is not going to take out. ঠিক আছে? So this point should be clear. So this is to be point to be clear. Yes, that is position. Then you going for the reaming. Okay, what is the technology of reaming and where to do reaming, where not to do reaming? There are few questions to be answered here. One is that this controversy is there, or applications of your rimming, particularly in compound fracture. There are studies says that earlier there are 1 or 2 studies shows that while doing the rimming in a compound situation, the chances of infection is high. Subsequently, in subsequent studies also shows no. They are saying no. If you do the rimming, that is infection rate is same with that of your Colossian compound. So recent trend is to go for rimming. They are saying that rimming is giving better. What is another advantage of doing rimming? Another advantage of doing rimming is you can enlarge the size. In case of your unrimmed nail, particularly which is selected for compound fracture situations, you necessarily go for a smaller nail. And if you go for a smaller nail, the chances of metal failure is high. Yes, you are going to find the smaller nail, huge man, you are patching a product because you cannot put a bigger nail without doing rimming. Probably this will go for metal failure because this is incompatible. Patient is very huge, your nail is very small, probably it is not going to serve your purpose. It will fail. So that is another problem with unrimmed. So recent tendency is to go for rimming both compound and close. One point, that is one. And doing the rimming also there are few techniques you are supposed to remember. One, that is rimming and supposed to initially the flexible rimmer initially end cutter, giving a track. Then you subsequently increase the increment 0.5, 1 point. And finally it is the rimming size and the nail size is difference between how much to be here? 1.5 to 1. That means if you are doing 10.5, so you are supposed to select a nail of 9 or something like that. 1.5 to 1 should be difference between the rimming. Now, few important things are there. Supposing this part is very much grossly comminuted, you have passed the nail. What you do in this area? What about the rimming tendency here? They do not try to do rimming at the comminuted fracture site. You do the rimming here, go, and in this area where there is a comminution, you better push it, then do the rimming the distal part. Yes, step by step also you do the same thing, so as to not to rimming at the comminuted area. Comminuted area you push it, then do the rimming subsequently. And the size of the rimming, see, 1. Number 2, why this sound of shutter is coming out, then this is the point where you have to stop. More you rim, you can cut, but you are also losing normal bone as well. You are essentially cutting the, it is true that bigger size of nail is getting better still. But to achieve this, if you do cut more and more nail, more and more bone, probably you will do finally more damage. So that is a limited one also, but it is true that smaller should not be, smaller is not very ideal. You have to be a ideal nail, and that is the difference there. Is it clear to you? Oh, that is one. And never start rimming before you enter the point. Yes? Yes? Never start rimming, otherwise you will cause lot of damage to the soft tissue. And you also make it a habit of doing, keeping the soft tissue protector. Sometimes you do not have a protector, can you think some additional thing you can do? It is the big bore syringe, 20 mm syringe, you can take the piston out, the other part you can cut, and then it can be used as a protector there. That is a simple technique to prevent the wrapping of the soft tissue around. Are you getting my point? The syringe you can cut it, you can use that one also to give the protections to the soft tissue. As such protectors, tissue protectors are available, and try to preserve it. Right? Do not do unnecessary damage to the soft tissue. That is one. So rimming. And finally another thing for going for rimming also, let's see the rimmings are, see the diameter of this part is always bigger than that is. So if you do a rimming of this and you forgotten about this part, your nail will go up to this, But final sitting will be another point. It's a hard bone. If you do more damage, there will be splitting also. So over rimming of this area is important thing. So do not forget about the over rimming. Then after rimming, then the second stage is to go for the exchange of the guide wire. Nowadays, of course, most of the surgeons they prefer to do not flexible but a straight rimmer, hollow rimmer through which you can do. In those situations, of course, you may not go for a ball tube guide wire, but you can go for straight guide wire also. Get my point? That is, if you are doing a, but in case of flexible rimmer, do not try this, because if there is a injury, then it will be very difficult to take out the part of your flexible rimmer. So you do not do that. You can do only in situations where you are giving a straight rimmer. Yes. Then oversize of this, over rimming of this part is very important. Okay. Then go for the exchange of this your guide wire with that of your with a sleeve. Yes or no? You are removing and you apply the guide wire. Next point is that resting of this here, this part is okay. But while putting the nail inside, never try to do forceful hammering. So your do is this always doing by the handwork. Go steadily, go handwork. Even if you are sometimes resistance is there, try to rotate the nail, go zigzag way. But if you try to do forceful hammering, probably it will be more dangerous. It will cause more damage to this bone and splinting or something, some problems will come out. So never try to do that thing. You always try to do hand pushing. This must. Only in final resting, of course, a firm push may be useful to rest it in resting, but not in between negotiating. While final resting, you may go for some sort of push. Otherwise, you do not do hammering while you are in middle. Otherwise, it may be very difficult situations for you to have this overcome. Then while there is final sitting, then you go for this interlocking. That part it is hand and most of the time free hand, and this is your most of the time with your jig. Now question arises, what about the hole here? This hole is oblique hole. Some are seem not, it is round, this is your oblong shaped. Why so? Dynamism. Okay, while doing the dynamism, while putting the screw, can anybody tell where exactly the screw lodges? It is upper part or distal part? Take a screw. That means what I mean, my question is that if your screw is like this also, or it may be screw like this, what should be position of the screw while you are passing? It is here or here? No, do not know. It should be here. So that while you are going, that this nail is passing, then it will be here in this area. So the nail while you are going, it will go like this. This screw should be here in this area while resting. So while you are removing, in dynamism, which screw you are going to remove? This screw or that screw? This screw. This screw you remove. Then what will happen? This screw, why it is resting on top? Now it will go like this, like this, like this. Nail will go like that, and this will give additional compression at the flexor side. So that is the advantage of the situations, and you know how to do it. But what to do with the dynamism? As such, what is the principle of dynamism? It helps in particular transverse flexor. Do not try it much in the oblique flexor or comminuted flexor. It may collapse. Overlapping may be there. But while doing dynamism, principle is that which segment is short, which segment is big. The shorter segment should not be go for dynamize, but always try to find out the longer segment in a situation while you need to do. So you try to, in this case, of course, this screw is meant for this there. You can remove it and you can do the dynamizations later on. Yes. So this is your actually the techniques, how you supposed to do. What are the indication? What are the contraindications you supposed to know? And in these situations, what particularly in case of fused knee, extended knee nailing should be done, can be done with a suprapatellar approach. But conventionally, we are all accustomed to do infrapatellar. And DR instrument is not the same with that of instrument. You have to have not different instrument group set instruments. So the problems will be always there, but you have to be cautious what to select, what not to do for, what not to do. Then sometime if you are not taking a proper X-ray, you may not see the distal medullary cavity. Another problem, obliterations of medullary cavity, some deformity is there, some angulation is there, you cannot negotiate it. So full X-ray and correct AP and lateral views are also important to go for it. So decide this. Otherwise, you may have some problems there. So though it is a commonly practiced surgery, even then one should be very careful while taking up, particularly see the knee movement, see these flexors, see everything before going for this here. So do you have anything to ask? Sir, आपको कुछ पूछना है नितिन भाई? Anybody, any question?
No sir, clear.
Clear, very good. Shankar